first speaker tonight we might just head on to. It's Toni Docherty, who is going to present from New South Wales, where she works in the Central Coast Area Health Service. She is the community program pharmacist for the health service and a PhD student with the University of Newcastle. Her PhD topic broadly covers OPAT, and we're really excited to hear what she's got to say about some of the issues around elastomeric infusers and devices. So, Toni, if you want to start sharing your screen online, I'll mute from this end.
Thank you so much. Okay, so yeah, my name is Toni and I'm the Community Programs Team Leader Pharmacist from Central Coast Local Health District in New South Wales, Australia. And today I'm going to talk about a project we did in our service that reviewed the efficiency of elastomeric pump devices in the clinical setting. And I'll also quickly talk about a piperacillin tazobactam infuser residual audit that is currently in progress. So our service is located on the central coast of New South Wales, which is about 100 kilometres north of Sydney. The Central Coast has a population of about 350,000 people, and our health service has approximately 40 virtual beds. The Central Coast Local Health District has 4 separate hospitals servicing patients who live over quite a large geographical area of 1,800 square kilometres approximately. So it's quite well known that treating patients at home increases hospital capacity, it's cost effective, it's preferred by patients, it reduces patients' exposure to hospital-acquired infections and causes less disruption to families, especially for paediatric patients. Therefore, it's not surprising that HIF and OPAT services are growing, so it's quite important that the devices we use to administer the intravenous antibiotics to patients at home are safe and effective. So the aim of our study was to measure the infusion lengths of intravenous antibiotics administered to patients from elastomeric devices in the clinical outpatient setting over a 12-month period, and to review any impacting factors on early or late finishing infusions if observed, such as infuser storage, temperature, and antibiotic solution type. But before getting into our project and results, I thought it was useful to quickly revise how the elastomeric infuser device functions and consider the optimal conditions that relate to the accuracy of the device. So the antibiotic solution is contained in the elastomeric balloon, and as it deflates, it provides the force required to push the antibiotic solution through the tubing. A flow restrictor inside the end of the tubing restricts the flow of solution. So the manufacturing company advises that the elastomeric device, called the infuser, pictured here, which we used in our study, should flow over about 24 hours plus or minus 10% under these conditions, which are using glucose 5% as the solution, which it's used to calibrate the device, taping the flow restrictor to the skin so that it's exposed to approximate temperature of 31.1 degrees Celsius, or skin temperature, storing the fill port approximately at the same height as the flow restrictor, and that the devices are used with catheter sizes of 22 gauge or 3 French. But if the devices are used outside these conditions, then the flow rates may deviate more than this. So to summarise this concept, the flow rate can increase the higher the device is stored above the flow restrictor as the temperature increases and as the viscosity of the solution reduces, and vice versa for reductions in flow rates. And studies conducted in the laboratory setting have demonstrated these concepts, and they're also outlined in the Baxter Professional Infuser Guideline. But what's not really known is how this translates into the real-life clinical setting where we use these elastomeric devices every day. Do they mostly empty close to 24 hours, and how often do they deviate from this, and by how much? And does the temperature, storage locations, different antibiotic solutions influence how fast or slow they flow? So there's limited time to discuss a literature review of the topic, but data is generally lacking about the efficiency of antibiotic-filled elastomeric devices in the clinical setting. This study by Hobbs and colleagues in 2019 conducted in the laboratory showed that flow rates from elastomeric pumps filled with distilled water deviated from those stated by the manufacturer. And when the height of the infuser in relation to the flow restrictor was changed or back pressure was applied, further deviations of flow rate occurred. And they also stated that in the same conditions had little effect on flow rate of the battery-operated pump that they looked at, and that studies of actual volumes delivered to the patient in the real-world setting are needed, which is what I'll talk about today. So in our study, we provided paper questionnaires to all patients being treated with an antibiotic containing elastomeric device in our HIS service over a 12-month period, with one side completed by the patient and the other by the nurse. And interestingly, when we first started this study, we assumed that many of the infusers were actually finishing early, since a lot of the nurses had noticed on many occasions that the vancomycin infusers were empty at the time they visited and when the vancomycin level was taken. But in general, we weren't really sure whether the infuser would empty before the nurse arrived, around the time the nurse arrived, or wouldn't be empty at all. So on the questionnaire, we asked the patient to record the time the infuser emptied, if before the nurse visited, and the location of the infuser storage during the day and overnight. And there was a picture of an empty infuser to refer to. And we asked the nurse to record how long the infuser was attached to the patient and the volume of any fluid remaining in the infuser. And there were also pictures to refer to. In the pharmacy, we recorded everything else, such as the antibiotic solution type, the indication, and the date of therapy. So we collected data from 266 infuser treatment days from 37 patients over a 12-month period. But as you can see here, on 170 occasions, the infuser was removed unemptied. Considering our aim was to measure infusion lengths, having so many unemptied infusers was a bit disappointing and also actually quite surprising, but it also highlighted the fact that unemptied infusers were often being removed in the clinical setting, and it was potentially a problem and probably something we really needed to know about. So for our data analysis, we had three scenarios. Firstly, the infusers that were empty and the patient recorded the time of emptying. Infusers that were not empty when the nurse removed the infuser, so we couldn't be exactly sure when they would have emptied had they had a chance to empty. And thirdly, the unknown group, where either the patient forgot to record the time it emptied or it just wasn't completed correctly. So first of all, I'm going to describe the group of patients where we've recorded an actual infusion length and where we knew what time the infuser emptied. So overall, only 73% of the infusers emptied in the expected time to empty as suggested by the manufacturer of 24 hours plus or minus 10%, and there was a fair amount of variation within this time range as well. The remaining 27% of infusers emptied outside this time range, either before 21.6 hours or after 26.4 hours. It's also likely that the late emptying infusers were underreported here due to the high number of infusers removed before they had a chance to empty when the nurse visited at 24 hours or more. And we also included 3 non-emptying infusers in the analysis here, since they emptied later than they were not empty later than 26.4 hours. So we could be certain that they would have been late emptying infusers. So the emptying times for each of the antibiotic solution types is shown here. The group of infusers emptying early consisted mostly of vancomycin, doses ranging from 600 milligrams to 3.5 grams. So our initial assumption that vancomycin infusers were emptying early was correct. But we also had a few benzopenicillin 7.2 grams and cefepime 3 grams. Piperacillin tazobactam 13.5 gram infusers were difficult to capture since they were mainly removed unempty. On the one occasion where we had an emptying time for piperacillin tazobactam, it was 28.35 hours. So, and speaking of the piperacillin tazobactam, I just wanted to make a quick side note here and look at them on their own, just to illustrate further why we didn't capture the times to empty for all the infusers, and particularly for the piperacillin tazobactam. We collected data on 38 of them, all of which had a strength of 13.5 grams, and 35 of these were not empty when removed. 3 were empty, but on 2 occasions, the patient forgot to record the time it emptied. And it is also important to point out that 4 of them were half full when they were removed. Going back to our group of infusers with known finishing times, interestingly, the cefazolin 6 grams and flucloxacillin 8 grams emptied within the expected emptying time ranges, with cefazolin emptying between about 22 and 26 hours and fluclox between 22 and 25 hours. So if we look at the group of infusers that were removed not empty, this slide shows the number of empty and unemptied infusers corresponding to each nursing visit time. The red indicates the number of infusers removed unemptied, and the green refers to the number of infusers removed empty. And for the yellow, the empty status wasn't recorded. There were quite a few early nursing visits, with 55% of visits occurring before 24 hours, which could account for some of the non-empty infusers removed, but there was still a substantial number of infusers that were not empty when the nurse visited at 24 hours or more. In fact, if we just look at those infusers that were removed after 24 hours had lapsed, just over a third of infusers were still not empty when removed by the nurse, which is more than we expected. I suppose the most important thing about reviewing the unemptied infusers was to review the volume of fluid remaining to ascertain the significance of the unemptied infuser. Lower remaining volumes may not have had much of an impact on treatment success, but obviously higher remaining volumes may be more likely to cause poor treatment outcomes, particularly if there were consistently high volumes remaining over multiple days. And it's also important to remember that these antibiotics in solution are stored in temperature for 24 hours and will have different degrees of antibiotic degradation, which may also reduce the overall dose. So the additive effect of degradation, as well as some partially administered doses on the total dose administered, needs to be considered. But for the infusers that were removed unemptied for 24 hours, 2 infusers were removed half full. And for the other 36 infusers, the volume remaining was less than 120 mils. And this was actually one of the limitations of our research, since there could have been quite a large difference here in volume remaining for this one tick box option on the questionnaire for the nurse. Obviously, 100 mils remaining is quite different to 20, for example, so it's a shame we couldn't capture that better. However, we could capture the times when the infuser was removed half full, greater than half full, or full, and this occurred on 21 occasions out of our 266 episodes of data collection. So on these occasions, only half or less than half the prescribed antibiotic daily dose, or on one occasion, no dose, was administered to the patient, which is important to consider. Also, on all these occasions, except one, these infusers that were half full or more were removed by the nurse from 17 to 23 hours, where it could be expected that the infusers would be closer to emptying. And had these infusers had a chance to run to completion, there's a good chance they all would have emptied late. So to assess the independent effects of factors like temperature, infuser storage location overnight, and the type of antibiotic solution on the rate at which the infuser emptied, we analysed and compared infusers that emptied within 24 hours against those that took longer. So in a clinical context, it's ideal for the infuser to be empty by the 24-hour mark, aligning with a scheduled nursing visit, which is the reason for our chosen criteria. We employed multivariable logistic regression to statistically evaluate and illustrate the likelihood of an infuser emptying post the 24-hour mark based on the type of antibiotic solution, season, and storage location. So looking firstly at overnight infuser storage location, the graph on the left is from our previous study where we recorded the temperatures that infusers were exposed to over a 24-hour period after they were first attached to the patient. And as you can see here, the average temperatures recorded off the bed were much lower than on the bed or under the blankets. So when we analysed the impact of different overnight infuser storage locations on infuser emptying times, we found that infusers had a higher probability of emptying after 24 hours when they were stored off the bed overnight, where the temperatures were coolest compared to the other storage locations. Similarly, this graph is also from our previous temperature study, which showed substantially warmer temperatures in summer compared to winter in our area. So when we analysed the impact of different seasons on infuser emptying times, we found that the infusers had a higher probability of emptying after 24 hours when they were used in winter. For the different types of antibiotic solution, that piperacillin tazobactam 13.5 grams, interestingly, we didn't have any 18 grams in this study, had a much higher chance of emptying after 24 hours than the other antibiotics, and vancomycin had a much lower chance of emptying after 24 hours. So our findings in the clinical setting support those from a study conducted by Perks and his colleagues in 2019 that calculated the flow rate and total volume infused from a Baxter infuser device over a 24-hour period in the laboratory setting. The devices in this setting were maintained at 31.1 degrees Celsius, and the device was kept at the same height as the flow restrictor. All the pumps emptied by the 24-hour point, except for flucloxacillin 12 grams and the piperacillin tazobactam 13.5 and 18 gram pumps. And this study demonstrated that dose affects flow rate from elastomeric devices, and that prescribers should be aware that the higher doses of drugs over about 12 grams may result in less than 90% of the volume of the infusions being delivered. And this is where the temperature and storage are kept constant throughout the administration period, which can be difficult in the real-world setting. So this is an example case from a patient treated for malignant otitis externa in our HIF service. We now use a Mobifuser elastomeric device, and following on from the quality project I've described today, the nursing staff now record infuser residual volumes for all patients when removed in the patient's notes. So the Mobifuser has an infusion volume indicator, which makes it slightly easier for nurses to approximate the volume remaining without referring to pictures. So this patient was treated with piperacillin tazobactam 18 grams, and the volumes remaining in his infuser are plotted on the graph for each day of his treatment. So obviously we found this patient example quite concerning. As you can see, on many occasions, the patient was only administered less than or equal to 75% of his prescribed dose, and there was an average volume remaining of 52 mils when the nurse removed the infuser. I should point out, though, that there were early nursing visits during this period, and so on the 3 occasions where 100 mils was remaining in the infuser, the nurse visited from 18 to 21 hours. But the volume remaining when the nurse visited after 24 hours was still quite high and ranged from 60 to 85 mils on 11 occasions. It's important to note that throughout this period, there were no documented issues with the patient's PICC line. The nurses documented that the line was flushing well, the PICC external measurements were okay, and the flashback was observed. Note also that we use 4 French picks, which have larger lumens than the recommended 3 French picks recommended for use with elastomeric devices. The patient did admit that he stored the infuser off the bed on some occasions and that his house was very cold. So I suppose this example case can also show what's possible when there's a combination of impacting factors, such as varying nursing visit times, a high-dosed infuser, which can slow the infuser in a cold environment. So reviewing this patient led us to audit all of our piperacillin and tazobactam infuser residuals over a 12-month period, which is still in progress. And it's shown us so far that this issue of residuals is not unique to our example patient. So the preliminary data from this audit has shown that regardless of how long the infuser was attached to the patient, 61% were not empty when removed. And of these not empty infusers, 79% of them were the 18-gram ones. But if we do look at the infusers where the nurse visited after 24 hours, so account for the time between nursing visits, the piperacillin tazobactam infusers were not empty on 49.5% of occasions for both doses and 56.9% for the 18-gram strength alone. And the average volume remaining for the 18-gram infusers was 38 mils. And interestingly, in the PERC study I mentioned earlier, the average volume remaining at the 24-hour mark was 34 mils, which is comparable, but I suppose in our case, the volume remaining in the infuser was recorded any time for when the nurse visited from 24 hours. So it's not exactly the average time at exactly 24 hours. So basically our 12-month infuser emptying study concluded that infusers may often be removed unemptied, volumes remaining may be substantial on occasion, and that temperature from different overnight storage locations and seasons can have an impact on whether the infuser will be empty before the 24-hour mark when we expect the nurse to visit. And different antibiotic solutions may also impact the emptying rate. And at this point, it's probably good to mention what patients and clinicians can do to reduce the impact of temperature and storage on flow rates as best we can. This includes storing the infuser in an appropriate place during the day and night, avoiding extremes of temperature, and taping the flow restrictor to the skin so it's exposed to optimal skin temperature. The patient should also be encouraged to notify the nurse if the infuser is not emptying as expected or emptying too fast or slow, obviously. And nursing staff should also be encouraged to document volumes remaining in unemptied infusers and report these to the treating doctor when they're substantial. So in summary, I guess clinicians should be aware that the elastomeric devices are not perfect and to be aware of infusers emptying late, which may be more often than expected, or sometimes early as well in the clinical setting. And higher doses of antibiotic may also slow the flow rate, such as the piperacillin tazobactam 18 grams. A few infusers can often be removed unemptied and residual volumes may be significant on occasion, meaning that patients are not receiving their full dose. In general, it would be beneficial to visit the patients exactly or close to 24 hours apart, since consistently early nursing visits may impact further on the residual volume in unemptied infusers. But in some settings, such as ours, where our patients live over a large geographical area, this is not always possible. So for infusers that are not empty, we've decided in our service to document the remaining volume in the patient's notes and report back to the treating doctor and the pharmaceutical company. And we're also trialling using top-up doses for patients on piperacillin tazobactam 18 grams. Counselling patients and educating new HIS clinicians on the possible impacting factors such as temperature is important to reduce multiple impacting environmental factors in the clinical setting, as just discussed on the previous slide. And for our service, we feel that the residuals noticed so far in our piperacillin tazobactam 18-gram infusers are concerning enough to use a battery-operated pump for these doses, and we're currently investigating this option, which we'll probably also use for the vancomycin infusions to assist with interpreting vancomycin levels. Reporting issues with residual volumes in infusers to the pharmaceutical company is obviously extremely important, and I know a lot of the HIS pharmacists in the Sydney area are actively doing this, and this can encourage ongoing elastomeric device review and improvement. And I believe that there is a new elastomeric device about to be introduced that should administer antibiotics with high viscosities or higher doses at a faster rate, but I don't believe it's yet available, and there's no experience with it in the clinical setting yet. So obviously further research in this area would be helpful, and it might be easier in a self-administration model where the patients can change the elastomeric device at the same time each day, and there's less reliance on the timing of nursing visits. And on a final note, our study did show that infuser flow rates can slow down in cooler environments. So I guess clinicians should consider this when cooling elastomeric devices, for example, for antibiotics with poor stability, in case the flow rate slows down too much. And that basically brings me to the end of my presentation. Thanks to my supervisors at the University of Newcastle everyone from APAC and Hospital and Home, Pharmacy, and the AMS team at CCLHD. And thanks for having me. And I hope my presentation has been useful. Thank you very much.
Oh, thank you. That was a super interesting presentation, and certainly something we probably don't give enough thought to. I'm sure there'll be lots of stuff in the Q&A at the end, but we might keep moving through the presentations and then we'll come back to you.